Okay.
Hello.
Welcome. Hello, guys. Let's start. Hello, guys. I am Dr. Bahzat Kaka from Rogin Dental, marketing manager for Middle Eastern market and North Africa. I would like to welcome all attendants to our new Rogin educational program. It's our pleasure from Rogin to serve all dentists everywhere. This is our first webinar with talented Dr. Mohd Aldawla from Yemen. He has a master degree in endodontic, and he's a lecturer in Sabah University as well as Sana'a University. The topic of our lecture is factors related to instrument fracture, which is an important topic, and we may face it daily in our clinic work. So I would like also to welcome Dr. Mohd Aldawla and everybody. And Dr. Mohammed, the webinar is yours.
Okay, thank you, Dr. Abu Yusuf. It's my pleasure to be here with you. And yes, as Dr. Yusuf said, we all care about removing broken instrument from the teeth, but we try to not to break them. Why not try to not break them? So this will be our topics: how to know the factors that cause broken file instrument and how to avoid them. So let's start our webinar. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I am Mohd Aldawla from Yemen. I'm an endodontist. I'm so glad to be here to start our webinar with the Rogin company. We all care about removing broken instruments from teeth, but try not to break them from the first place. Here are some tips and tricks to avoid breaking them any instrument inside the root canal system. As we know, root canal treatment may require the use of variety of instruments. Any of these instruments may fracture inside the root canal system during its use. This fracture will reduce or compromise the cleaning and shaping procedure with a potential impact on the treatment outcome. Therefore, if we can reduce the number of instruments, we will reduce the chance of instrument fracture. There are some instruments we have been used to use them, but nowadays we can replace them. For example, barbed brush and Lentino spiral. We can roll them out and not using any more of them due to this instrument can be replaced by the rotary motion, the rotary file motion. Rotary file motion in the direction of clockwise will remove any contents inside the root canal system. So this motion can replace the barbed brush. On the other hand, rotation of the rotary file in counterclockwise direction will remove or they will move any materials to the direction of the apex. So this motion can replace the use of the Lentino spiral, which used to fill the canal with the non-sitting calcium or the sealer. Several factors have been implicated in the failure of root canal instrument, and many studies have attempted to explain their individual contributions. Today, we will discuss some of these factors affecting the instrument fracture. One of the most important factor is the operation-related factor. As the rotary files went to the market, doctors deserted manual files. They become so happy with the rotary files and this new handpiece, the endomotor. This thing reduces our ability to feel the stress that applied on the file. Reducing the tactile sensation, explain the file fracture is high on rotary compared to the manual file, because the dentist or the practitioner, we cannot feel the amount of the stress applied in the file inside the canal. Therefore, the chance of breaking the instrument become higher and higher. So adequate training is needed before doing any rotary instrumentation in your patient's teeth. In the training, from the training, you should improve your tactile sensation to avoid any aggressive penetration into the root canal system by applying apical direction. And from the training, you should improve your sense when the rotary file is about to bind inside the canal. So you should remove or withdraw the file outside the canal before any torsional overload occurs. So our goals is, each time we are preparing the canal, the auto reverse action which happens when the overload, when the stress exceeded the presetted torque, this action, which named auto reverse, it happens from when you do root canal treatment the first time, many times. For example, if it's your first time to do rotary instrumentation on an extracted tooth, from the beginning of instrumentation until you finished, it happens auto reverse motion, for example, 10 times. Your goal in training, after doing root canal treatment for 10 teeth, the number of auto reverse should be reduced. Should not be the same 10 times in each canal. Why? Because the less the auto reverse happen, the more your fingers got experience and sensation, high sensation, to feel the stress that is applied on the file inside the canal. The second factor that play a role in instrument fracture is the anatomy. And this is anatomy, for example, the access cavity. The definition of an adequate access cavity has undergone several changes throughout the last years. A complete access cavity should still allow unobstructed visual access to the orifice, to the root canal system, as a funnel to guide the instrument to the first curvature inside the root. What does this mean? This means that the step of coronal shaping or enlargement of the coronal third, this step is considered as an access cavity. It's not a step that included inside the shaping of the canal. No, when we do enlargement of the coronal third, this is considered as a part of the access cavity. For examples, in this case, as we see, this long fractured instrument, it's clearly from the X-ray that the reason of this fracture was the inadequate access cavity. As we see, dentinal shelves is still there, the roof of the valve chamber is still there. So this is anatomy, or this is dentine, which wasn't removed, applied high stress on the file during its rotation. And this is what caused the fracture of this case. Also, this is case when the doctor tried to do an access cavity from caries-driven access cavity. As we see, the instrument fractured, even though the canals are very wide. They are not narrow canals. In upper central is a wide canal, but the fracture happened not due to complexity of the anatomy or curved canal or narrow canal. It is because inappropriate access cavity. Another reason of file fracture due to the anatomy is the complexity of the root canal configuration and the curvature and the sharp radius canals. So fracture appear more often in molars compared to premolars and anterior teeth, and also appear more often in mesial canal compared to what? Distal canal or palatal canal for upper molars. This is finding explained by the overall morphological complexity of the molar root canal system. For root canal configuration, as we know, there may be two canals in the same root. And if this is the case, we may have even a type 2 canal, Virtusi classification, or type 4 canals. And we all know the difference between type 2 and type 4. Type 2 canals, they begin with two orifices and they end with one foramen. The two canals join either in the middle third of the canal or in the apical third. But in the other hand, the type 4 canal, they begin with two orifices and they end with two foramen. So the dentist should have an idea about the anatomy of the canal before before instrumenting this canal. Because in case of type 2 canal, the joining part of the merging of the canals usually have a sharp curvature. This sharp curvature, always the file fracture there when there is any apical or aggressive pressure to the file, and this is joining part. So the file or become more undergoes more stress in this area. So our goal to evaluate the anatomy before instrumentation. For example, if it is type 2 canal, we were gonna focus in one canal. We're gonna reach the apex, prepare this canal until we finish the instrumentation procedure. Then we will define the point of the joining, and we will prepare the second canal to the joining, not to the apex. The most anatomical factor related to the file fracture is the curvature. And when I say curvature, I mean that you should deal with every canal as a curved canal, even though it's appear in the periapical X-ray as a straight canal, but in reality, there is sometimes a bacolingual curvature of the file during its cross from the orifice to the apex. But this is curvature in this direction cannot be evaluated from the periapical X-ray. It will be seems in the periapical X-ray as a very straight canal, but during their cross, there are multiple curvature, bacolingual, mesiodistal in the same time. So we have to deal with each canal as a curved canal. About the curvature, there is another factors that play a role in this difficulty or the simplicity of these curvatures. It is called the radius of curvature. Let me explain what does it mean, the radius of curvature. The radius of curvature, it means from the beginning of the curvature till the end of the curvature, this distance, when this distance decrease, when the distance decrease, it means the curvature is so difficult because there is a sharp change in the pathway. For example, this is two teeth, which we are see it in the screen. This is tooth number A, and this tooth number B. From this point, the beginning of the curvature from this point till the end of the curvature from this point. This distance, if we consider, for example, 7 millimeter. Comparing with the tooth number B, the beginning of the curvature started from here. And the end of the curvature finished here. The distance, let's say it's about 4 millimeter. If I'm going to ask you, which one is more difficult to instrument it or to shape which tooth, A or B? The answer is B. B is the more difficult. Why? Because the radius here is 4 millimeter, while here the radius is 7 millimeter. And this 4 millimeter means that the canal was straight. Suddenly, there was a sharp curvature. But here, the curvature started from the middle third, and it's continuously until approximately apical third. This long curvature does not makes the file highly stressed compared when the canal is straight, suddenly it's curved. And you can know this from the road when we are driving our cars and there are sudden turn in the street. We should slow our speed, but when there is a big curvature, we shouldn't decrease our speed. We can deal with this curvature without reduce the speed of the car. Okay, here is another example. If I say which one, and this example in the same tooth, two roots or two canals, mesial canal and distal canal, and both of them have a curvature, but with different radius. So from the look, if we say which one will be the more difficult, mesial root or distal root or distal canal, the answer is the distal canal. Distal canal are more difficult. Why? Because the canal here is straight. The curvatures begin from here and the curvature end here. This is the distance of the radius. And for in the mesial root canal, the curvature started from here, curved, and finished the curvature here. And the radius is more larger than the distal. So the distal are the low radius, which means the more difficult. Another idea about the curvature is the position of the curvature. Where is the location of the curvature? Is the curvature located in the apical part, as here, or in the middle third, or in the coronal third? And according to the position or location of the curvature, this will determine the simplicity or the difficulty of the case of the curvature. In this is two examples, the right one and the left one. What do you think? Which one is the more difficult? Case number A or case number B? From first view, you're gonna think that the difficulty will be in number A, as it shows a sharp curvature compared to the B, which has a slight curvature. But from the literature, a severe curvature in the apical third of the canal could be less threatening for file failure compared with the moderate curvature in the middle or coronal. So the closer the curvature to the orifice, the more difficult, the more stress will be applied on our files. And to explain this, let's see how millimeter remain after the curvature the file will engage. Here from this curvature, about 1, 2, 3, 4, 5, 6, let's say 6 or 7 millimeter after curvature. While here our file will instrument this area, this part of the canal with less stress. And the file will face a stress only for short millimeter, for about 4 millimeter stress. But here the file will have an stress, or an stress will apply on the file for about long distance. Therefore, the position of the curvature also play a role in the difficulty of the instrumentation. Okay. As we talk about curvature, let's discuss how to manage curvature in a safe way. There is an endodontist, Dr. John, who gave a technique. He named the technique a zone technique. This zone technique, the principle of this technique explained that we should prepare the canal in two parts. One part, which called the coronal zone, and this part is where the file can go to this area passively without any apical direction, apical insertion. And the remaining part of the canal are named what? The apical zone. It is the zone where the file will find or will be applied under a lot of stress. For example, in this route, on this canal, the coronal zone should be the straight part of the canal, which maybe will be in this area. And so this area is the coronal zone. The remaining part of the canal will named what? Apical zone. So after dividing this canal into two parts, and a straight part, coronal zone, and the curved part, the apical zone. Our next step is what? First, we determine the working length. We will place file number 10 and place it until the apex, use the apex locator, determine the working length, and let's say the working length was 22 millimeter. Next step, you're gonna take the file number 10, the same file number 10, and place it inside the canal without any watch winding. Just place it passively until it stops. In the other words, take what the canal give you. Takes what the canals give you. So place the file without any watch winding. Why? Because with watch winding, the file will reach the full apex. Will reach the full apex even under curvature or any irregularities of the walls. No, what our purpose is to just evaluate the coronal part of the canal, which is the straight part of the canal. So placing the file passively without any engagement or apical pressure or watch winding until the file stops, cannot go more. Remove your hands and measure this length. Let's say in this example, we measure the length and the file goes for 16 millimeter until this point. So this area it is named what? The coronal zone. So what's the next step? The next step, you're gonna take your rotary files. For example, 20 taper 4, 25 taper 6, 13 taper 4, and all of them, you are going to use them to shape. This is 16 millimeter of the length, only 16 millimeter. Of course, after each file, we're gonna use file 10 as a patency to the full length to guarantee there is no blockage will happen beyond this, the tip of the files. After instrumenting all of the rotary files to the 16 millimeter, then now we finished preparing the coronal zone. This is coronal zone. We finished preparing it. Now the canal is ready to the next step, which is preparing the apical zone. So what's the purpose of preparing the coronal zone before apical zone? The purpose of this, that to ensure our files, when it goes to the apex to prepare the apical zone, there is no engagement on the coronal zone. Because when the number of the engagement of the file inside the canal is increased, the more the chance of file fracture. We don't hope our files become engaged to its full length. No, we need it only part of the file should be engaged inside the canal, while the other part free. And this principle will reduce our file fracture. So the zone technique, after we remove any engagement of the file inside the coronal third by preparing the coronal zone first, then our engagement in the apical zone will be engagement that does not cause file fracture. As you see here, 25.6 can reach full length. Only the engagement on about 3-4 millimeter of the file, while the rest of the file are free from any engagement. Let's take this example. This case came to me, to the clinic. The patient had root canal treatment, and the previous dentist during root canal treatment had the fracture instrument, so he tried to bypass, but unfortunately, he did a perforation where he didn't know he did the perforation, and he do overfilling, and the Gutenberg goes to the maxillary sinus, which caused severe pain to the patient. Before see the treatment, how we treat the case, let me ask you why this file fractured easily. What's the reason, or what's the difficulty of the anatomy that caused this fracture? And if you focus, yes, that curvature of the file, the roots of the mesial root begin in the coronal third. This coronal third curvature makes the file fracture more susceptible, because the number of millimeters remain for the file to prepare it after the sharp curvature, maybe it's very long, and that's why once the doctor just goes inside the canal, it fractured immediately the file. So what we did in this case, we removed the overfilling butyberca from inside the maxillary sinus. Next step, we removed the broken instrument. Then we did retreatment to all the canals, prepare the canals, and do obturation. And from the obturation X-ray, what you can notice that I enlarged the coronal third enough. And this enlargement allow me to reach the full length of the canal without any risk for another fracture instrument. After we finish discussing the operation skills related factors and the anatomy factors, let's discuss now about the instruments, the material we buy and we use for shaping the canals. And this is instrument related factors. We're gonna discuss some of them. And one of these is important point of instrument related factors is the size and the taper of the instrument. So there is a very strong relationship between the size and the taper of instruments and the torsional failure and the cyclic fatigue. And these are the two mechanisms why our rotary instrument fractured inside the canal. To understand both of these is mechanism of fracture, torsional failure, and cyclic fatigue, let's discuss the mechanism or the concept of these fractures. The torsional failures, it occurs when the tip of the file become engaged inside the canals, while the rest of the body still continue rotate. This lead to a fracture of the instrument in the tip here. While the cyclic fatigue, the reason of the fracture that high stress are applied in the curvature area. The tip of the file has no any stress, are free rotating. But the fracture here in the cyclic fatigue is due to overuse of the file, and this is overuse of the file inside a curved canal, causing a tension and compression on the side of the file in the curvature area. So this video will explain each of these is cause of file fracture. For torsional failure, the reason of fracture, as we see, that part of the canal are fixed, part of the file are fixed, while the rest continue rotate. On the other hand, the cyclic fatigue is due to a continuous bending action, compression and tension, and this lead at the end to the fracture. Okay. So after we understand the difference between torsional failure and cyclic fatigue, let's see what's the shape and the size of the size and the taper of the files goes under these two causes of fracture. As we see, the more the smaller the taper of the file, the more the stress distributed from the tip of the file, and this lead to torsional fracture. While, on the other hand, the larger the taper, the less the stress distributed on the tip of the file. What does this mean? This means that when there is a large size of file and large taper, the file are more resistant to torsional failure. It will not fracture due to torsional failure easily, but it will fracture due to cyclic fatigue. As we saw the video, cyclic fatigue is due to bending. And the file with the large taper, large size, has no flexibility because it has a large core of metal. And this results in a cyclic fatigue, a fracture. While when we have a small taper and size, the file can resist a cyclic fatigue because it has a small, thin diameter. So its flexibility high, so it will not fracture easily due to cyclic fatigue. It can go to curvature, curved canal, and prepare it with more safety. But on the other hand, if there is any binding or any engagement in the tip of this small instrument, in a small file, it will fracture easily because the body of the instrument will rotate and the tip is engaged, it does not rotate. Because it's thin core or thin diameter, it will fracture easily. So cyclic fatigue, it happens even under the hands of experienced dentist or endodontist. While in the small taper or torsional fracture, it happens due to its small diameter. It will happen even with a new instrument. Even this instrument was the first time you use it, but you didn't prepare the canal, you didn't do the glide path, smoothing the canal to ensure there is a smooth passage of the canal till the apex. There is no any narrowing or sharp binding of the canal that cause a fracture. So the fracture will file will fracture even in the first time to be used. Therefore, as a beginners in Rotary endo, I advise my students and my college to reduce the torsional fatigue, which is caused due to binding of the tip of the file. That when they are using the rotary file, always do instrumenting the apex with a manual file before rotary file of the same size. For example, if you're gonna prepare 25 taper 4, before it, use the same size 25, but with taper 2. This file will goes to the full length. It will not engage in the middle and the coronal because the file before it was larger than its taper. So it goes to the apex. It will prepare the apex to 25. So when you place then the 25 24.4 taper rotary, the rotary will not be engaged in the tip because it was already prepared by the manual. The same idea with file number 30. Before placing a rotary file 30 taper 4, place the manual 30 taper 2 to enlarge the apex. So the files of 30 goes rotary goes to inside the canal. It will not be bind at the apex because 30 manual and 30 rotary are the same size of the tip, but they are different in the taper. But the tip, they are equal, the same. Another properties of the file that play roles in the fracture of the instruments is the metallurgy of the nickel titanium. As we know, nickel titanium are more flexible than stainless steel, and this is what we studied in our college when we were students. But from nowadays, there is a new treatment, a heat-treated nickel titanium. It's a nickel titanium, but it was treated under high temperature. This high temperature gives this instrument a super flexibility, becomes more flexible. Why? Because this instrument was manufactured under about 45 to 50 centigrade. This is treatment on the file makes the file has a different properties. The nickel titanium has two faces, even it's one alloy, but it has two faces, and each face of these faces has its own properties, different properties, and these faces are named austenite and martensite. Martensite are the phase where it is the crystallines of the nickel titanium are arranged in a different way compared with martensite, which is in a crystalline phase where the crystalline ions are arranged due to the high temperature during manufacturing. These phases has a different properties. For austenite file, and these are the conventional nickel titanium. The old nickel titanium are austenite. Austenitic nickel titanium has high cutting efficiency, high torque resistance. What does this mean, high torque resistance? It means that when the file when a torsion applied to the file and stress applied to the file has a more resistance to unwinding. So we cannot see a conventional nickel titanium with unwinding flutes. That's because it has a torque resistance. But their disadvantage, they are less cyclic fatigue, which means they are become more weaker when we are placed them inside the canals, curved canals, and they are less flexibility. The flexibility are more than stainless steel, but they are less compared with the martensite nickel titanium. Martensitic nickel titanium, they are high cutting cyclic fatigue resistant. They are more flexible and they are more resistant to cyclic fatigue, which means we can use them for several cases with caution, of course. And their disadvantage that they are less cutting efficiency and they are less torque resistance. And that's why this is new alloy. We can see them after using them inside a difficult canal, we can see them, they are unwinding because they have a less torque resistance. So the companies, they are manufacturing nickel titanium. This is new heat treated nickel titanium in this area. Some of the companies make their files completely martensite. Some of them make them in the middle, so they get advantage from here and from here, martensite, from austenite, and some of them place in them. But our advice from nowadays, don't buy austenite files, which is the previous one. Not a heat treated, the previous one, because they are more prone to fracture compared with martensite. So that the heat treated on the files makes the file more flexible and more pre-bending, which can be the file can be pre-bent before inserting in the third molar, upper 7 canals, limited mouth opening, so the file can be bent easily and reach or for example to bypass a ledge in case it happens. The last factors we will discuss today is the technique used related. The technique you are following during shaping of the canal play a role in the incidence of file fracture. As we know, there are a lot, more than hundreds different system and different rotary files in the market, and this makes the dentist confused which company to follow and which kit or sequence to use, and the sequence itself are not well understood among the dentists, and this what one of the reason why when they use a specific sequence or the rotary file, the file become more fractured and they have more cases with file fracture. And so to avoid this, we need to give a review about the safe sequence of rotary root canal instrumentation. Number one, the first step in root canal instrumentation is the access cavity. And as we said, the access cavity does not finish until we prepare the coronal third. And for this purpose, we use always, and we find always a short file with a large taper. It's the shortest file in the sequence in any kit you buy, and it has the largest. And this file, its purpose just to prepare the coronal third. Maybe some companies name it an orifice opener or coronal prefraling. All of them has the same purpose, to prepare the coronal third. The second step is the glide path. And the common for these files, they have taper 2 files. These files has a taper 2. So either manual files, 10 and 15 and 20, or rotary files, 10, 20, 15, and 20. All of them with taper 2. So this step is called what? Glide path. Focus with me, guys. This is the sequence you should follow. Number one, to use this file for coronal enlargement. Then we're gonna use either the manual file or the rotary file for what? For glide path, which means preparing the canal from the orifice to apex with a highly smooth passage with taper 2. That's it. Then the last step is the shaping of the canal, which is usually we find it in the kit 20 taper 4, 25 taper 4, 30 taper 4, 35 taper 4, and this is extra file which is 25 taper 6 for a large canal or central upper lateral palatal canal, as the dentist determined during the case. Okay, so let's now to discuss an example, super flexi file from Rogin, and let's discuss this sequence to understand from our basic sequence, which we explained before, how we gonna order this files, when this file will goes to inside the canal, what are the files before this file should be inserted inside the canal. As we discussed together, first step is the access cavity, second step is the glide path, and the last step is what? Shaping of the canal. Okay, for the access cavity, the first file will be inserted here, as we said, large taper and short files. Why they are short? Because we don't want them to go to the apex. Their purpose just to prepare the coronal third. So this file will go as access cavity step. The second step is what? As we said, they are the files that have a taper 2, either manual or rotary. Here, let's check the sequence of super flexi file from Rogin: 20 taper 4, 25 taper 6, 30 taper 4, 35 taper 4. So from this sequence, there is no glide path files. What does this mean? This means that I will bring file number 10, taper 2, manually, 15 taper 2, 20 taper 2, manually or rotary, as you like. I will prepare the canal after file. These is 3 files. This is a mandatory step to do it. You should not skip this step unless you are really well experienced. Otherwise, for safe rotary endo, this step should be followed. After preparing these 3 canals, 3 files, then we're gonna check this to finish the sequence. 20 taper 4, because it is taper 2, more than taper 2, this goes for the last step, which is the shaping steps. So this is 4 files at the end will goes to the shaping. So our steps will be like this. First file to prepare is the glide pre-flaring or orifice opener, and because it has a large taper 9, it will prepare only the coronal third, and it will enlarge our coronal third. Then the second step will be the glide path, which included file 10, file 15, and number 20. For number 10, it will be the same working length plus 1 millimeter extra working length plus 1 millimeter, and this is called what? Patency, as we know, to avoid blockage. The second file will be 15 taper 2. The third file will be 20 taper 2, because it's a large file 20. We're gonna assume that it will prepare the apex, only the tip of the canal enlarged for size 20. Then the second step will be what? Preparing using the super flexi file from Rogin, 20 taper 4. Here, 20 taper 4. If I am gonna ask you guys, this file, what do you think in which part of the canal it will be engaged? In which part of the canal it will be bind with the dentinal walls? Let's check the sequence before it. The orifice opener taper 9, because it's taper 9, it enlarged the coronal third. So we're gonna assume that this file will not be engaged in the coronal third, because the taper 10, taper 9 was larger than taper 4. And because in the steps of the glide path, file 20 already enlarged the tip of the canal. So this is file, it has a 20 taper 4, but it has the same tip of 20 taper 2, because the size are related to the number of the tip of the file. So because these are 20 and this 20, we're going to assume that this file will not be engaged at the tip. Only it will be engaged in the middle of the canal. And this is what happens during instrumenting. The second canal, the second file is 25 taper 6. Let's discuss together. In the coronal third, this file will not be engaged because it has a taper 6, while the orifice opener has a taper 9. It is larger than 6. But what about the middle and the apical? In the middle, because this has a taper 6, while this has a taper 4, so we can assume that there will be a high engagement here in the middle, because taper 6 is larger than taper 4. What about the tip? The last file engaged the tip was 20, but here is 25. So there will be engagement in the tip. So we can assume before doing the instrumentation, just from the first look to the sequence, that this file will be the difficult file in the sequence. Why difficult? Because it has a large distance to be engaged inside the canal, the middle third and the apical third. And from there, because of this, if you check for this Super Flexi file kit, the company instruction from Rogin company, the torque for this file is 1.5 Newton centimeter. But for the 25 taper 6, the torque is 2 Newton centimeter. Why 2? Because the company already knows from the sequence of the taper, this file will be engaged in more number of the contact area in the file, in the middle of the file and the apical. Therefore, it needs high torque to allow the file to continue rotating and do cutting to the dentin. What about the third file of shaping, which is 30 taper 4? From this, with the same principle, let's see where the file will be engaged. Because the orifice opener has a taper 9, while this has a taper 4, so we're going to assume that this area will not be engaged. And what about the middle third? The middle third, because the previous file, which is 25 taper 6, is larger than 30 taper 4, so we're going to assume that the middle third will not be engaged. Only the tip of the file will be engaged, which is 30 larger than 25. And this is what happens in the canal. When you reach to this file to instrument the canal, where the previous one was 25 taper 6, you're going to notice, guys, that the file goes to the canal more easily, more smoothly, compared to the 25 taper 6, which you find more resistant, more difficulty. And the same happens with 35 taper 4, which only the tip of the file will be engaged to enlarge the apical part. And this is the safe sequence you should follow when you are using Rogin files from Super Flexi file. If someone are going to ask us, what is the sequence of the Rotary file? Are they step back technique, or ground down technique, or standardized technique? And the answer is, although all the files go till the apex except the pre-flaring file or orifice opener files, it looks like they are standardized technique, which the standardized techniques stay for all the file reach to the full length to prepare the apex. But the truth, they are crown down, because as you see, the contacting area of the file during the whole sequence, it goes from the coronal till the apical third. So although all the files are going to the full length, but it is a crown down by playing the taper size, by going around the tapers. Files with the large taper, then files with less, but files with less taper, but with large size of the tip. This playing in the size of the taper, it is the reason how we are preparing the canals in a crown down technique. Okay, so this is the safe sequence for Super Flexi file. The company give us this first file, and this is 4 files. So our job to include, this is 3 manual files, or you can replace them with a rotary glide path files. But let's discuss if someone took this the sequence of the kit and goes directly to prepare the canal without doing a glide path. This file, the first file will be orifice opener to enlarge the coronal third, and he or someone will do working length of file 10. And if you jump directly to the second file in the sequence of the company kit, 20 taper 4, what do you think? Where will be the engagement? It will be from the middle to the apex, because you didn't do glide path and enlarging the tip of the canal. And this huge contact area for a small file, as we said, small file with tip engaged, this will cause a torsional failure, which happens even in a new files. What about if you have a luck and the file doesn't fracture 20 taper 4? You're gonna have a high luck, increase luckiness to have a fracture with 25 taper 6. And with this, what ends with jumping from the glide path sequence to directly to the canal shaping sequence. Let's take another example from Rogin company, which they are named R-Shaper. For R-Shaper, let's discuss. We have the first file are short and large, taper 10. So this file goes for what? For access cavity step. The second step are what? Glide path. And as we said, glide path equal taper 2. And this is the second file from the R-Shaper. They are their size are 16, not 15, 16, and they are tapered from 2 to 4. What do they mean? Do they mean that from the middle half of the file taper 2, and the rest of the half of the file are taper 4? So we are considering them as a taper 2, and because they are taper 2, they are goes for what? Glide path step. So the company place one file for you as a glide path, and the rest of the file 20 taper 4, 25 taper 4, 30 taper 4, and 25 taper 6 in case of large canal. So the sequence for these file R-Shaper files from Rogin company will be like this. First file will be the orifice opener. Then you're gonna use file 10 manual file, and you're gonna use the second file, the company file, which is 15 or 16 taper 2. Then you're gonna use manual file 20, size 20. After finishing the steps of glide path, and focus here, that's the company. Focus here, that the company give you one file for glide path. So they give you 15, so you're gonna finish manually with 20. Then we're gonna go to the rotary files, which is 20 taper 4 for the canal shaping step, 25 taper 6, 13 taper 4. So I guess now, guys, we understand how to know or to order the sequence, the safe sequence for root canal preparation. It's not the same sequence comes with the kit. Even the company order the sequence, brief layering file, and the rest of the file. You should study this kit and knows which file should be followed by the other files. The last step or the last factors related to the technique we are using or following is the handpiece or the endomotor. As we know, first endomotor motor used for rotary was the low speed handpiece, which is air driven motor. And the problem with this is handpiece, they are continuous rotation. They have no torque control. The file will continue rotate. If there is any engagement, it will happen one or either of the things. Either cutting the dentine or file will be fractured. Therefore, the companies started to manufacture the first endomotor. The first endomotor has what? A torque control, where you select a preset torque according to the company manufacturer instructions. Then your motor will rotate. When it reach the stress to this level of the presetted torque, it will goes directly to a motion called auto reverse, which is counterclockwise direction to allow the file to become free and out of stress. But nowadays, the endomotors become more smart and more safe by an properties that's called OTR. The OTR, optimum torque reduce, for some companies name it like this, and other companies name it reverse torque reduction. For any names, the purpose is the same. What is the difference? The difference that the file, when it rotates and reach to the presetted torque, it will goes as reciprocation. It will change its motion to reciprocation, a 90-degree counterclockwise. So the file become loose, and it will goes again clockwise to allow speed of the preparation and continue preparing the canal. And a lot of the articles appeared advising for this property because of this OTR motion the root canal instrumentation became more severe and with less file fracture. Debris removal. In every insertion of your file inside the canal, you have to remove the debris from the file for two reasons. The debris you collected by the flutes of the file from the canal should not be returned again to the canal. You should clean it outside the canal. The second thing, that when the flutes filled with the debris, the file become less sharp and less effective in cutting. So inserting the file full with debris inside the canal to trying to prepare the canal, you are just increasing the friction and the stress on the file. You are not cutting efficiently. And therefore, Dr. Allen Nasih, he advised a technique which he named it SSC, which is single stroke cleaning. To clean after each insertion of the file, clean it with a swab filled with spirit, alcohol. And this was one of the techniques that reduce the file fracture, because every time you clean the file become more sharper, or become sharp and ready to cut dentin again with less stress. Last advice in our lecture is to try to avoid reusing a broken instrument, or reused sorry, not broken instrument, or the broken instrument, you're gonna throw it. I mean the existed instrument. If you're gonna place an instrument in a curved canal, especially the large taper, which has a less cyclic fatigue, you should to remove this file from your bench and try to use a new one. The last point also that affect our instruments is the sterilization and the sodium hypochlorite. The presence of the file inside sodium hypochlorite, either inside the canal or outside the canal during sterilization, will cause an effect negative way to the alloy and the surface of the nickel titanium, which lead to a cyclic fatigue area and cause a fracture. And that's why Dr. Ohio advised in his articles that our dental assistant, when they are cleaning the files, we should advise them to place it in one concentration of sodium hypochlorite, not full concentration, as they cause less corrosion to the surface of the file. At the end, what do you think, guys, in this case? How many fracture instrument inside this premolar? Let's see. do you believe there is still one more file? The fifth file still remaining in the canal. This is the last file to be removed. I guess this case should be registered in the Genesis as the broken file inside the canal. Maybe the dentist tried to bypass, but each time he tried to bypass fracture. And this is the message of this lecture. Why to treat a broken file? Why not to avoid breaking them inside the canal from the beginning? At the end, guys, thank you for being in this webinar. I was so happy to be with you, and I want to give a special thank to Dr. Abu Yusuf. He's the Middle East agency of the Rogin company, and also to Mr. Khaldun Al-Asbahi, the agency in Yemen for Rogin company, for their help to make this webinar happen, and which makes me so happy to be with you guys and to share some tips and tricks about file fracture and how to avoid them in our daily cases. Now, let's see some questions from the attendance. The first one is saying, asking, talk about step back technique. Yes, about step back technique. These techniques are not more used in rotary endo, as we explained, that rotary instrumentation depends on crown down technique, because this technique, crown down technique, approve their safety in preparing the canal. The main problem in endo that our focus is how to reach the apex from the beginning, and this is the big step. This idea makes all the problem or complication in endo. You should never focus on the apex. It is, and this is a sentence that I always repeat it to my students. It is not how to reach the apex, it's how to clean till the apex. So our focus should be is cleaning what the canals give you. Goes to the canal passively, see what is the length you're gonna go to there. For example, to the middle third, then start to prepare the middle. Don't be a hurry to reach the apex. Start to prepare the middle third. After that, go to the apex. And this time, when you go to the apex, you're gonna go it with safely, because there is no engagement in the coronal part. There will be a big space for your files to go till the apex. So step back technique are not more advised in clinic. They are still teaching step back in universities for the students, but when in clinic, we prefer crown down technique, especially when we are using rotary files. The second question, why we don't use 25 taper 4 in between? Yes, maybe, Wissam, nice question, Wissam. Yes, you can use, but as you know, from jumping from, there is a wedge principles in rotary file. If you place a two file with the same size, but with different taper, this will place a file in highly stress inside the canal. For example, as you mentioned, if we use 25 taper 4, okay, then the next file will be 25 taper 6. The principle states that it will be engaged the same length, highly stress, or will be applied on the file. That's why they make it always the taper 6, 25 taper 6 between 24 or 34 to jump from large taper. So you're gonna prepare the middle third in enough space. Then 30 taper 4 will go easily without any engagement. Zainab asking, please again explain about SSC motion. Voice become unclear at this point. Okay, I will explain it again. In this technique, let's go to the slide. Yes, here it is. In this technique about the SSC motion, Dr. Allen, he advised us that after each insertion of the file inside the canal, we should clean this file from debris remove the debris from the flutes of the file by using a cotton. For example, dental assistant will take the cotton roll and place the cotton roll inside the spirit or sodium. So after each insertion of your file inside the canal, you're gonna swab your file to remove the debris from the flutes of the file. So each time the file will goes again to the canal, it goes with free from debris. The flutes are empty, so they has more efficiency in cutting and more space to collecting more debris. Okay, Zainab, I think I make it more explain clearly. Sarah Sharif, how can how can we use the rotary file in calcified canal? Okay, Sarah, a nice question and a nice topic to talk about. Listen, guys, there is a misunderstanding about rotary files. People or dentists are thinking that if they are facing a calcified canal, they're gonna refer it to a specialist so he can open it because he has a rotary file. And this is a misconception. Rotary files are designed and manufactured not to open a canal, to open a closed canal. No, their job only, the rotary files, to enlarge an already open canal. What does this mean? That means when when we are facing a calcified canal, we place the rotary files again, in the corner, and we open this file by using a manual file. That's it. Taper 10, taper 15, gradually by tactile sensation, and we're gonna see how the file are bind, and we can understand the much of the tip of the file are under stress by touching the plastic, the handle of the file, and see the bundling motion. And this will give us an evaluation about the calcified canal. And this is a topic we need to make a webinar for it to discuss it. But let me give you the main message about calcified canal, that rotary file should not be used to open calcified canal. It is the job of manual file. Rotary files only do an enlargement for an already open canal, which has been opened by manual file. Okay. From Gaida, when should we stop at file 25 and when we should use file 30? Very, very clever question. I like this type of questions. So this is one of the era in endo. Should we stop at file 25 taper 6? Should we continue instrumenting to 30 taper 4, 35 taper 4? Who is the control in charge to tell us which size we should stop? The correct answer, there is no specific size. You should not apply a specific presetted size in your head before you preparing the tooth, and you're gonna say, I will finish this is apex to 25, distal 23. It's not something to take it as a standard for all the canals, because each anatomy has its own shape. For example, if I give a shoes with one size, can this shoes be placed by all the audience? Of course no, because each one of us, their foot has different size. It's the same applied to the apex of the canals. So how we can decide it? Let's take what the canals give you. As I said, let's the canal tell you which is the appropriate size for their apex. And this can be done by a new technique, which is called by visual gauging. Visual gauging, I will give a short explanation, because I already posted a video before 2 weeks or 1 week, explain this thing, Ghadia al-Jaboubi, thing. Visual gauging, it's a two Italian endodontists who give this technique. They says that the debris collecting at the tip of the file for about 3 to 4 millimeters with a clean white debris, this is the appropriate size. You should stop preparing the apex. If the debris are not present in the tip of your file after preparing, that means you go to the next file. If your file 30 does not collecting debris in the tip, go to 35. If 35 doesn't collecting debris in the tip of the file, go to the 40. So let the canal give you what is the size of the file. That ensure the touch of all the walls, the 4 walls of the apical part of the canal. A question from Mu'tasim. Your advisable master apical file. It's the same question like Gaida. The same answer, Mr. Dr. Mu'tasim. Master apical file should be selected according to the appropriate size of the canal, not about pre-seated size in our heads. And I will, inshallah, give a video lecture about subject master apical file and how we can determine the appropriate size for each canal or each case. Salam, Dr. Salam, he's asking, what is your advice when we have a difficulty, a C-shaped canal, about searching and enlarging this canal? A big thanks to you. Thank you, Salam, and thank you for your attendance. Yes, C-shaped canal, it is considered as the most difficult root canal anatomy for even experienced dentists. And the reason behind this difficulty is not how to shape this anatomy, it is how to clean this anatomy. So C-shaped canal, we depend on the irrigation and activation very, very, very much to clean this area of difficult anatomy to reach it by our files. And my advice in these cases to place sodium hypochlorite, to do activation or ultrasonic, to do heat, intracanal heating by using the heat plugger for the system B or thermoplastic injection guttaperca. Use the heat plugger inside, fill the canal with the sodium and place this heat plugger to do heating of the sclera inside the canal. Then when in the step of obturation, I prefer in these cases bioceramic sealers due to their flowability and their non-absorbable and non-shrinkage. So I can guarantee this that I can fill 3D obturation in this difficult anatomy cases. Question from Dr. Majid Al-Haddad. glide path ممكن تشرح لنا عنها بالعامية عن عاميك. Okay. He's saying, can you explain glide path? It's glide path. It is a simple first step before preparation of the canal. You're gonna use file 10, 15, 20 manually. The purpose of this step is to have a smooth passage from the orifice to the orifice. So after you're doing access cavity and you are using, after use orifice opener to enlarge the orifice, you're gonna take your file number 10. You're gonna measure the working length using the apex locator and confirm it with the periapical X-ray. Then you're gonna do a wash winding motion until you reach the full length and do the filing or the reaming. I prefer the reaming. I don't love the filing motion near the apex because the filing motion has a problem. It cuts the dentine in the direction of the apical and cut dentine in the direction of the coronal. I have no problem with the cutting coronally, but the problem is when you are cutting apically, you are pushing the debrits more apically, and put it in your mind, apical extrusion of debrits equal pain post-operative. So when you are reached near the apex, always instrument the canal by the reaming motion. What is the reaming motion? You are going to the full length until you reach the full length. You're gonna twist your file quarter, then withdrawal, remove the file coronally. This motion is called reaming. It takes time, but with less pain after treatment, post-operative pain, because it does not cause apical extrusion of the debrits. So Dr. Majid, the glide path is following the file number 10, 15, 20 to the full canal, smoothing the canal. Then you goes to a rotary file for shaping with a safety manner that you guarantee that your tip of the file will not be engaged or bind inside the canal, which causing torsional fracture. Dr. Hani Al-Abdali, he's asking how use a rotary system in retreatment. Okay, in retreatment, there is a specific file for retreatment, and these is files, the difference between them from the conventional files for shaping of the canal is the design of the tip of the file. For retreatment files, their tips are pointed, are sharp. On the other hand, the conventional file which are used for shaping the canal, the tip are non-cutting to avoid any ledging. So why retreatment, the tip of the file is sharp or cutting tip? Because we're gonna place this tip inside the cotubercle. So it should be cutting, so it can be doing a drilling through the cotubercle. But in my experience, I just use the same rotary files for shaping. I use them for retreatment. I don't buy retreatment files. I just get used to use the same shaping files with the cases with retreatment, but with some adjustment by placing chlor inside the pulp chamber to allow fluids so my files will go more easily. I make high speed. I increase the speed a little bit so it can remove the guttaperca. I advise not to remove all the guttaperca till the apex. As you go to apex, as the more engagement will happen to the file, which may lead to fracture. Remove the guttaperca till the middle third. Apical third depend on manual file. Take number 10, 20, 15. Remove the rest of the guttaperca and the apical part manually for safety. Okay, Dr. Arana, her question are, she's asking, how do we take care to not go beyond the apex? Please guide. Okay, about the how to avoid going beyond the apex. If you are using the Endomotor from Rogin, the last version from them, there is an properties in the device that allow us to connect the rotary with the apex locator in the same time. If you did like this connection, it gives you an option that it's called apical reverse. So when you are doing instrumenting to the canal, while the Endomotor are connected at the same time with the apex, the device become more smarter. Once the file reach the apex, the Endomotor goes auto reverse. What does this mean? This means when you reach the apex, the tip of the file touch a periodontal ligament, which give a signals to the apex locator. The apex locator will give a signals to the Endomotor. The Endomotor will goes a change in his direction from clockwise into counterclockwise, and this will avoid you to go beyond the apex. The file will goes directly out of the canal. Even if you push, you're gonna feel that your file is going out of the canal. If you are not using rotary files, depending on the apex locator to determine the working length and doing your stoppers, measuring your stopper at the working length, by this simple measurement, you're gonna be okay without going any beyond the apex. But by the way, with file 10, it's okay to go beyond the apex because this is called a patency. This is a technique. It's called patency technique. And because it's small number, it will not go do any harm. It will not push any debris apically because it's a small file. But your question is related to a big file, for example, 30, 40. Yes, we should not go beyond because our target is from the orifice till the apex. Question from Dr. Abdurrahman: how many teeth does a file use? This question cannot be answered scientifically from any dentist unless he answer one use, single use, because each teeth or each case has its own difficulty. So if I'm telling you that I use Rogin files for about 30 canals, 30 canals, it may be fine with me because each of these 30 canals was central incisor or anterior teeth. But if you apply my answer, this answer or this experience to a molar, it will not last for 30 canals. It may last to 20 canals, and then it's gonna fracture. So there is no answer for your question, Dr. Abdurrahman. There is no specific number when we should remove the file. No, it depends on your sensation. If you prepare a canals where you found yourself pushing high stress on the file to reach the apex, throw this file. Throw this file. Don't ever think about to use it again because maybe it's gonna do another or couple cases, but it's gonna fracture, and fracture, as we know, It's not a simple management to do it. And it needs its equipment, dental microscope, retrieval kits from Circamed, from other company. It needs a lot of facilities. So bother yourself by buying another files better than bothering your heart and see the fracture instrument in your dreams at night and have a nightmare. And this is what I think it's the best answer for your question is it depends on the case you are using this file on. دكتورة شروق asking in Arabic ممكن تعيد إجابة ليه ما نستخدم فايل 25 تيبر 6. We can use, who says we cannot use 25 تيبر 6? We can use 25 تيبر 6 files between 24 and 34. No one mentioned that we cannot use them. In the slide, I placed 25 table 6 and explained how to use it. Dr. Zainab, how we can apply Gutenberg and canal shaping just by manual preparation with apical curved canal? Okay, in a curved canal using manual instrumentation, the principle will be the same, Dr. Zainab. You're gonna place the file till passively inside the canal, see what length it can goes. For example, if the canal is 20 and the file goes for 15, you're gonna stop for 15 and you're gonna instrument manually the files from 10, 15, 20, 25, 30. Then you're gonna do use the file 10 again to the full length and prepare it as we discussed it, zone technique. About the Gutenberg, yes, you may find some difficulty to place the Gutenberg to the full length, and this is the difficulty is due to what? Due to that Gutenberg as a soft material. So if the walls are irregular, your Gutenberg will not be reached easily to the apex as the file do. So how to solve this problem? By doing circumferential filing. What we are when we are using a manual file and doing instrumentation, sometimes we are just instrumenting one wall or two walls, that's it. Then when we try to place the Gutenberg inside, the Gutenberg doesn't go to the apex because still the other two canal walls irregular, which makes the Gutenberg bend or become irregular. Therefore, when you are placing your file to the full length, you should determine which wall of the canal you're gonna smooth it. For example, this is the file inside the canal. When I place my file against the buccal wall, the rest of the part of the file inside the canal will go where? To the lingual. So when I place pressure into the buccal and do reaming and withdraw the file, I'm doing smoothing to the opposite canal, opposite wall, which is the lingual. And when I do insert the file again, I will push to the lingual direction. So my file goes to, see guys, when I push lingually, the files goes buccally. This is what happened inside the canal. When I go again to the lingual and my file pushing, touching the buccal, I will do reaming, which is quarter motion, and remove. This in this second tries, what I did, I smooth the lingual, the buccal wall. Again, I will insert again and I will push mesially. So I will touch the canal, inside the canal, the distal, smooth the distal canal. Again, insert for the fourth time, that move the file to the distal. So my file will goes inside the canal, touching the mesial. I will do a quarter engagement and remove, reaming. And by doing this circumferential filing manually, after you're finishing, your Gutenberg will be inserted easily to the apex as the file did. Okay, Dr. Zainab. Last question, Dr. Sarah Sharif, Rotary. She's writing in Arabic. I will read in Arabic and explain it in English for the audience, English audience. Rotary بعد التحضير بالobturation. دكتور لو سمحت ممكن تشرح لنا الobturation. Okay. She's asking about how to do obturation after rotary instrumentation. Okay, nice question, because this question will give us an opportunity to tell you guys one of the mistakes happened when the rotary file comes into the market. When the rotary files comes to the market, dentists thought that single cone technique is a fine technique that after we instrumented the canal, we finished with the with the file 30 taper 4, for example. So your Guttaberka should be 30 taper 4, and you're gonna place that Guttaberka 30 taper 4, place it inside the canal with the sealer, and cut the Guttaberka at the level of the orifice, and that's it. You finish the obturation. This technique is called single cone technique. Why single cone technique? You depend on your obturation by what? A one Guttaberka, which is the single cone technique. This technique proved with time its failure. It's a failed technique. Why? Because the rest of the canal, because our files, they are not shaping the canal to the same shape of the file. No, we are just shaping part of the canal, because most of the canal of the dental root canal system are oval shape. And they are oval shape. We are just preparing the middle part of the canal by rotary files, while the rest of the canals are not prepared enough or shaped. Therefore, our Guttaberka, when inserted as a single cone technique, the remaining space will be filled with the sealer, and we have no problem with bioceramic sealer, because bioceramic sealer, if it is used with single cone technique, it's not considered a single cone technique. It's considered a best technique, because the sealer, bioceramic sealer, it is considered as by itself as the filling material, and the Guttaberka in its technique is considered as a condenser, which allow the spread, hydrodynamic spread of the sealers, of the bioceramic sealer. But the problem with the single cone technique, when it is used with the conventional sealer, resin sealer, zinc oxide digenol sealer, all these sealer has a common disadvantage: shrinkage, highly shrinkage, resorbable with the time. So we filled the canal, our canal, with single cone technique, filled most of the spaces by the space by sealer, and a single cone inside the canal. See that the same tooth after 3 years, 2 years, 5 years, you're gonna extract this tooth and do sectioning to the canal. You're gonna see a Guttaberka stay alone inside the canal, no more sealer around it. What does this mean? This means a big space for bacteria to divide and to do contamination. The step of obturation, its main goal is how we take the space of root canal system. We are in a race, في مسابقة, between us and microorganism. Who will take more of the space of the root canal system? If we took all the space, so the bacteria cannot grow and do cell division and contaminate the root canal system. That's why single cone technique after rotary is not a good idea unless you are using a bioceramic sealer. Dr. Anwar, he's asking in Arabic. I will explain it in English. دكتور السلام عليكم. أنا عندما أشتغل بالروتري بالأسنان الأمامية أوصل وأحس أن تحضير القناة غير كافي ويحتاج أكثر حتى لفايل F3 أحيانا، فما هو الحل؟ Nice question, Dr. Anwar. He's saying what we already explained about master apical file, that we should not select a specific size of the file, of the master apical file. We should follow the canals. Dr. Anwar, he's following, he's listening to the canal. What does it telling him? He feels that when he reach F3, still he's not cleaning the apex enough, or not touching the apex area. I got your question correctly and answer it. Dr. Gaida Al-Jaboubi, she's asking, Doctor, please do more lecture like this one in the near future. Okay, inshallah, Dr. Gaida. Thanks for your nice comment. Inshallah, with the Rogin company, we will do more webinars, and you can follow me in my YouTube channels. I posted a lot of lectures there, and also in the Facebook. Thank you guys for your question. I think I answered all the questions, and it was a nice to meet you guys. And again, thank you for Rogin company for to make this webinar happen. Dr. Abu Yusuf, Rick Chan, and Khaldun Al-Asbahi. Thank you guys, and hope to stay well and see you in soon as possible.
Thank you. Do you hear me? Thanks, Dr. Mohd Aldawla, for this informative webinar. And thanks for all dentists who joined us and attending our webinar. We promise from Rogin that this service will be continue and we will do more webinars soon. And we have a lot of good things in near soon.